I'm Brian Rini. I'm a professor of medicine at Vanderbilt-Ingram Cancer Center. So 2024 for kidney cancer, I think the highlight was the KEYNOTE-564 adjuvant pembro survival data. I think it was at ASCO GU this year. We had previously seen disease-free survival advantages, FDA approval on that basis. OS was immature, but trending in the right direction on those first analyses, and then finally hit and was reported early this year. And it was significant because I think, when you're having a conversation with patients, it's always nice to say we can reduce your recurrence by X, we can make you live longer on average, by a certain amount. And so it just provides more data for a conversation with patients. There was discussion at the session about subsequent therapy, and as scientists and docs, we're never satisfied. We always want to dig in and analyze, scrutinize the data. But it really, I think, set the precedent that is a standard of care in this setting. I think most people give it or certainly offer it in that setting. And then, it's our job now to build on it, right? We're still treating, patients who don't need it, and we're still not curing everybody, et cetera, in that settings, but it's a nice foundation. Other 2024 highlights, there was some biomarker data at ASCO, main ASCO, from the AXI pembro data and from the len pembro data. And we've done a better job of biomarker development in kidney cancer. We're still not at the point of clinically useful biomarkers, clinically applicable ones. But I think we're starting to, from these big phase 3 trials, get the right samples, analyze them, use the most modern techniques, associate that with clinical outcome, and at least understand the biology of the disease better, which is, I think, the first step towards both biomarkers and better care. So I think, we're waiting, there's another wave of trials that'll come next year. So kidney cancer have been, I joked about only the every other meetings of KCA in the early days. Now it's almost like there's big data at every meeting. There's just so many phase 3 trials and activity in the kidney cancer space. It's refreshing. So kidney cancer landscape 2025. We're waiting on some combination trials. There's Merck has a couple trials, one called 011 in the second line setting of lenvatinib, belzutifan versus cabozantinib. And I think that's sort of a question for the field. Belzutifan was approved late last year. Oral HIF inhibitor with advantages in what's called the LIGHTSPARK-005 trial. Has become a standard of care in the refractory setting. And then the question of that 011 trial, and broadly speaking, is are VEGF inhibitors plus HIF inhibitors, is that going to be an advance? Is that going to be better than either one alone? And the 011 trial, which could read out next year, I don't know. It's event-driven, of course, will be the first first trial to sort of look at that. Not the only trial, there's others ongoing and planned, but I think that's sort of one of the next questions for the field is how are those going to play together. There's also a large frontline trial called 012, probably not next year, but I think these combination trials, there's also a trial in the adjuvant setting with belzutifan, so there's a number of combination trials sort of across the waterfront of kidney cancer disease state, so to speak, that I think will start to hit, and we'll see. There's also some actually phase 3 trials in the non-clear cell space, which is unique. Non-clear cell has been sort of the poor stepchild of clear cell for a really long time, and we're starting to get drug development in that space, including large randomized trials, which is sorely needed. So I think it's going to be another good year. I think mostly it'll be combination data. Our biggest effort in kidney cancer at Vanderbilt has been this OPTIC trial that we've been doing for probably a good year and a half, 2 years. This is a biomarker-based trial where we take frontline patients, we biopsy a metastatic site, we do RNA sequencing on that tissue with a collaboration with Tempus. We have a data collaboration with a third-party vendor. They analyze the RNA sequencing data, and then they assign patients what's called a cluster, which is based on another trial that defined clusters based on disease biology. And then we're giving one of 2 standard treatments based on that, ipi-nivo or cabo-nivo. And so it's an attempt to develop biomarker-based treatment, which, as mentioned, is sorely needed. It's a pilot study, it's 30 patients per arm. There's a lot of caveats to this initial effort, and it's been an enormous effort, but it's already been successful from an operations standpoint. We can biopsy people, get their RNA sequencing, and get them assigned and get them on trial within 3 or 4 weeks, which is a big lift. And we're starting to get towards accrual to one of the cohorts, and maybe by next year, if not, 12 to 18 months, I think we'll start to have some data, and it's my biased opinion is the kind of trial we should be doing, right? We got to put our money where our mouth is. Everybody talks about biomarkers, but don't really do anything about it. We need to do prospective studies or we're never going to get there. This has been a huge labor of love. Myself, Katie Beckerman, Scott Hake, many other people at Vanderbilt who've helped get this off the ground. It has funding from the DoD. So it's been a great, investigator-initiated effort. It's probably the most, it's definitely the most homegrown investigator-initiated study, and it's probably one of the most satisfying studies I've ever done. I obviously don't know what the results will be, but when you put that much effort into something, even just the success of doing the trial, let alone the results, is satisfying.